task for today is to talk about evolving frontiers. And what I will do is I will talk about a few things, not so much on the technical side, but more about clinical applications that people may not be aware of where they currently are, and also some of the recent data. And then I will spend some time also talk about an area that is, I think, one of the most exciting, oxygenation sensitive MRI. And since we have started even help start a program in Lagos, and their interests in Tanzania and in Cape Town. So I hope that Africa in that sense will take also a pioneer role in this new technology. So before I start, I want to disclose that I'm also involved in other activities. I'm also principal investigator and of the Canadian Alliance for Healthy Hearts and Minds. This is a cohort study of 10,000 Canadians, and then I'm scientific director of the Courtois Cardiovascular Signature Program, again a cohort study. Both aim to identify targets for prevention of cardiovascular disease. I'm also involved in software development that helps us analyze those data. So these companies that I'm involved in there are provide software solutions for more easier analysis of cardiovascular risk, and specifically, of course, also focused on cardiac MR. So I do not want to go through too much to basics. You have already heard about cardiac MRI. Among the different imaging modalities we have, cardiac MR is a very good global player, so it can do pretty much everything. While CT is the best in terms of morphology, but has not much else to offer. Nuclear has some focused applications for metabolic disease, but again, is not very good at the rest of it. Echo is a fantastic technology for bedside assessment of function of the heart, pericardial effusion. So in most of the emergency cases, it will be very useful. But once it gets more difficult, it is also limited there. Now, cardiac MR, and I'll come back to that later, is of course also limited by several factors: complexity, expenses, access to scanners. But I'll address some of that later. Now, when we talk about imaging, of course, a lot is these days about CT. And CT is indeed a fantastic technology, and photon counting CT is now making it into let's say the latest and greatest. But again, as I said, it gives morphology. And yes, there are some promises regarding plaque imaging and even some tissue imaging, but so far, the major role of cardiac CT is in ruling out coronary artery disease in a non-invasive fashion. Although it also has to use contrast agents, it also has to use radiation, things that are not only costly and require certain logistics, but also are a safety hazard for people. Now, cardiovascular MR is, from my point of view, the most powerful imaging modality we have. It is very versatile. We can look at function, we can look at perfusion, we can look at flow velocity, and we can look at certain tissue characteristics, which is maybe the single most important aspect. We can look at edema as a marker for acute injury, and we can look at scarring or other irreversible changes such as fibrosis. And more recently, we have started using in a lot of research projects oxygenation sensitive MR, which I will talk about later. So in a summary of the advantages, it's a safe technology, has a high spatial resolution, has a consistent image quality, is reproducible, has a relatively small observer-dependent, excellent tissue contrast, is very comprehensive, but scan times are still too long. So if we take an hour for a cardiac patient, that costs per se, at least in the so-called developed societies, costs about $500 every hour, and this does not work if you need more than an hour for scanning. So we have to learn how to use the scanners more efficiently, and I will talk about that. So there are a couple of unique contributions of MR. So areas and questions where only MR can give a really good answer. So MR, cardiac MR, is currently considered the gold standard for quantitative assessment of the heart. It is pretty unique in identifying tissue pathology. It can quantify flow and perfusion without radiation, and there are some new techniques. Now, as you may know, I have been involved a lot in myocarditis, so I will talk a little bit about that first. I know you have already heard about myocarditis, so can go through that fairly quickly. So myocarditis is actually more frequent than we thought. Almost every viral infection, systemic viral infection, can come with involvement of the myocardium. And if you look at troponin or ECG, you notice that regular influenza has a myocardial involvement in between 30 and 50%. So myocarditis is way more frequent than we used to think. On the other hand, the good news is it's typically not very harmful. So it is a disease that often heals, but sometimes it stays. So you can have persistent problems like pericardial effusion or persisting perimyocarditis. And sometimes overlooked persisting edema is a problem and can even lead to fibrosis. And myopathy, where this is becoming very interesting, and we have a paper in preparation, and there's a paper between a collaboration with a center in Portugal showing that patients with heart failure, but preserved ejection fraction, so these are often postmenopausal women, that they seem to have chronic relapsing edema. That explains why they have heart failure despite the normal ejection fraction, but the heart is stiff because of the edema. If you have a massive event in these postmenopausal women, we know the so-called stress-induced cardiomyopathy or Takotsubo. But this is just one end of the spectrum. Now, edema in the heart also happens in viral inflammation, and it's interesting to see that when you compare it with a healthy person's either short axis views with a water sensitive technique or for the radiologist a T2 wedge triple inversion recovery spin echo sequence, and in a patient with acute reperfused infarction, you see the swelling of the wall, but you can also see the bright signal intensity that is consistent with myocardial edema. In acute inflammation of the heart, this is more diffuse, often affecting a little bit more the inferolateral wall, but edema is not regional as in coronary artery disease. Now, these tissue characteristics are very important, and this is one message I always try to make people take home. One could argue, yeah, myocarditis, if the function is normal, you can basically relax, and then it will not be that bad. But here's an example of a 23-year-old patient who came in the hospital with ST segment elevation, so with acute, more severe injury. Then he received an echo, and the echo was deemed completely normal. And as you can see here in the long axis views and the short axis view, there are no significant wall motion abnormalities. Maybe a tiny little bit inferolateral, but that is only if you want to believe that. So one could argue, okay, if the function is okay, there cannot be much damage. But as you can see here, this patient has severe, extensive necrosis in the myocardium in almost every wall, especially inferolateral and anteroseptal. So this is a necrotizing myocarditis, and the patient had a troponin that was with a normal value of 14, was above 5,000, so it was significant injury. So a normal function scan does not rule out myocarditis or even severe necrotizing myocarditis. And to address that, we have already in 2009 published the first set of the criteria for myocardial inflammation by MR. And in 2018, they were revised, these criteria. And the good development with the revision is that by using native mapping, T1 mapping, T2 mapping, this allows now to establish these two criteria, the two major criteria, without contrast agents. So if you do a T1 map and T2 map, and the image quality is good, and both are positive, and this is a patient with a history consistent of acute viral disease, then this is a confirmation of the diagnosis. So these criteria have been compared with endomyocardial biopsy. This is just one of the several studies that showed that the criteria have a very high accuracy, and 92%, to correctly identify myocarditis. And accordingly, since August last year, and I have to say, after having worked with that for more than 20 years, it was one of the best moments of my career to see this enter the 2025 ESC guidelines, that these criteria, the so-called Lake Louise criteria, are now considered next to biopsy, just as good as biopsy, to confirm the diagnosis of myocarditis. Again, I have to stress the point that this has to be a patient with clinical impact. So pulling people off the street and looking at these is not all people with other disease, because they also may have myocardial inflammation. Myocardial inflammation is per se not specific to viral intrusion, but it is still it's still often informative. So MRI made it from being added to the clinical suspicion to confirming the diagnosis, and now it is basically on top of the pyramid. And to be honest, I think biopsy should not even be here, because biopsy has a lot of false negatives, and it's invasive. So this will not be necessarily clinically very useful test. So this is a class 1 indication. So cardiac MR scan in a patient with suspected myocarditis and potential clinical impact, because this may, for example, mean that this patient should not do sports, at least not on a high level, for at least 4 weeks. And there are currently no specific medical treatment options for viral myocarditis, but they are being developed, and therefore it's important to be prepared. So often myocarditis goes by, it's not complicated, and it goes by itself. But if we have more severe cases, it allows to establish the diagnosis. And then you also do not need coronary angiographies or whatever. Often these are young males that suffer from that. And so this is a new development in MR since last year, that it's not only in the American College of Cardiology, but also in the European guidelines. Now, another example for tissue characterization where it's important is amyloidosis. And this is something I also will talk about next week. The use of artificial intelligence to extract information from various images, and then to synthesize them. And in this case, what we have done in a collaboration between Montreal and Heidelberg, we used regular images, fed these images into the algorithm, trained an algorithm, and then had 3 patient groups: healthy people, people with hypertrophic cardiomyopathy, and people with amyloidosis. And amyloidosis, they had both AL or ATTR. And then we looked at, can we discriminate based on these images with artificial intelligence, one from the other? And these are the results. Of course, it was easy to identify healthy people versus hypertrophic cardiomyopathy. And so this would not be surprising here, that the area under the curve is basically perfect. It's also near perfect to differentiate between hypertrophic cardiomyopathy and amyloidosis. But if we take all together, we can also, with an area under the curve of 0.92, so with an accuracy that cannot be topped by nuclear medicine, differentiate ATTR from AL amyloidosis, which is important because for the one of them, for ATTR, there exists a specific medical treatment now. So then if we say, okay, but we do not want to have we do not have all the information, we just have imaging. Even then, you get to similar accuracy results. And then we took the next step and say, okay, what if we did not have the contrast agents, if we just use the scan data without the contrast enhanced images, and even then we had an accuracy of more than 85%. So this is a good medical accuracy for medical tests. So in other words, even if you do not use contrast agents in patients with amyloidosis, you can not only differentiate amyloidosis from other diseases like hypertrophy or hypertrophic cardiomyopathy, but also you can, with a high diagnostic accuracy, identify the type of amyloidosis. So this is, I think this is also important, and this should now be tested in larger populations and other populations, and hopefully then lead to yet another protocol that can be done without contrast agents, because contrast agents are expensive. They can, in very rare cases, but they can have acute reactions like nausea, vomiting, or even sometimes allergies. They provide a logistical problem, but of course, especially in countries where contrast agents are not produced themselves, they can be very expensive. I know that in South Africa, when I worked there in Cape Town, the contrast agent was just as expensive as the rest of the MR scan. So this is where we have to get better. And medicine in general, everywhere is too expensive. Yeah. So let me shift gears to perfusion, and you may have heard about that already. So perfusion scanning works by injecting an intravenous bolus of gadolinium, and then watch basically the accumulation of the contrast agent in the myocardium under regular conditions, and then under vasodilation. And in vasodilation, we have a kind of a coronary steal phenomenon. So the uptake is increased by the vasodilation, but in areas where there's a blockage, this cannot basically cannot get to the same level. So you see a relative difference between the two. In this case, you have a significant perfusion defect, but only a small myocardial infarction. So this, in this patient with symptoms, it will be a good indication to intervene, because there's a perfusion deficit and in viable myocardium. So this has been shown to predict outcomes just as well as fractional flow reserve. This was the this MR Inform study. Very nice study, because it looks at outcomes, not so much as accuracy, because accuracy is nice, but you have to show that the use of this technology actually improves outcomes. And the current gold standard for verifying the severity of coronary artery stenosis is fractional flow reserve. And in this case, these were randomized, these people, to either get this invasive study with angiography and fractional flow reserve, or get a perfusion scan and make a decision on intervening, yes or no. So outcome was the same, but there were actually less interventions in the CMR group. So it was more cost efficient to do that with CMR. In fact, this is a good opportunity now to say, cardiovascular MR in coronary artery disease is cost efficient if you use it. It saves so much money that within 7 to 8 years, you can buy a complete scanner from that, and or you amortize a scanner. So because you do not need a lot of the invasive studies that you otherwise would need, you can skip other tests like nuclear medicine, which is often more expensive because of the radioactive traces. Now, adenosine perfusion itself has been around since 30 years now, but there was always skepticism around. But a few studies recently have really made it very clear that first pass perfusion, CMR, is the most useful perfusion technology we have. And some of these studies are here. So this is the GATACAT-2 trial that showed that the diagnostic accuracy of adenosine perfusion with CMR perfusion outperforms SPECT virtually every time. So except for the negative predictive value and the sensitivity, there was an overlap. Not even then, nuclear was better. In all the others, the accuracy overall, the specificity, and also the positive predictive values was very clear, statistically highly significant, that SPECT is the better technology. And then it also was a question, okay, what's the prognostic value? And this is what was answered now and published just a few weeks ago. the prognostic value of an abnormal perfusion. So MRI was the only technology that could predict basically all the endpoints of the ischemia trial, which is still the largest trial that has ever been done on coronary artery disease. But here are some data that are not as such in the paper, but from this result. And this is very interesting and actually stunning. So if we look at the prognostic implications of a normal perfusion scan or a scan with mild ischemia, we see that none of these people with a normal scan or with mild ischemia had any events in the following 4 years. So the negative predictive value was basically 100%. Whereas if you had moderate ischemia, your event rate for the primary endpoint was 14%, and cardiovascular death or MI was 12%. And then in severe ischemia, it was even worse than 18 to 20%. So there's a very clear prognostic answer that comes from the perfusion scan. Moderate or severe means higher event rates. Now let's look at the other modalities. And there I couldn't initially even believe that. There was practically no significant predictive value of the other modalities in terms of the outcomes. In fact, the worst groups were the normal and mild ischemia in SPECT. Those had the highest rates of events. So that is true for pretty much all of them, at least mild ischemia. So echo also, if the echo was totally normal, they also had no events. But even if there was mild ischemia, could not differentiate further. So I think this is a very important piece of information. The prognostic value of cardiovascular MR adenosine first pass perfusion is unmatched. And this is also shown. These are just the Kaplan-Meier curves. And now the analysis of perfusion scans doesn't even require necessarily an expert, because we have now techniques that do an automated quantitative analysis of the perfusion. So you get a quantitative value and can even look at microvascular dysfunction. So this is another takeaway I want to leave with you. If there's access to cardiac MR scanner, I say this everywhere, and I'm happy to get into any discussion. There is no point in continuing SPECT studies on nuclear scans or stress echo or whatever. Then a perfusion scan is way more accurate, more prognostic, and also eventually cost efficient. Now, another interesting clinical application is patients who come with a myocardial infarction or looks like myocardial infarction. They have positive troponin, they may have ECG changes, but then their coronary arteries turn out normal. And it's very interesting. We have learned that through cardiac MR, that a quarter of them roughly still have myocardial infarction. So you can see, hey, even though the coronary angiography, they have myocardial infarction. So this is what you then can call MINOCA, myocardial infarction, normal coronary arteries. But then about 3/4 of them, or 2/3, it varies a little bit between the studies, have what we call a mimicker of MINOCA. So they mostly have myocarditis or stress-induced cardiomyopathy, Takotsubo. And this is actually not only more frequent than we think, but it's also very important, because if you send these patients home, oh, your coronaries are normal, then that's okay. So we don't worry. But if you know that they had acute myocarditis, if you know they had a Takotsubo, that has therapeutic implications. And only if they are normal, although this is in the more recent studies, less and less the case. You very often see non-ischemic injury in these people. So the diagnosis of an initial suspected MINOCA will very often be modified by cardiac MR, and because of the tissue characterization. Another important aspect of tissue abnormalities in infarction is hemorrhagic infarction. And I've considered this since many years as the most critical, dangerous, overlooked problem. Hemorrhagic infarction is a complication of acute reperfusion, of a reperfused infarct. So in North America and in Europe, almost every patient with acute MI goes somehow to a cath lab, and sometimes the time between the onset of the infarction in the cath lab is more than 4, 5, 6 hours. And while this still sounds good, in many of these cases, in fact, in more than half of them, you have a hemorrhagic transformation. And this is important. This has very important implications because hemorrhage not only leads to what we call microvascular obstruction, so there's no blood flow coming in, no contrast agent coming in into this area, but also it creates inflammation. The inflammation creates edema. Edema compresses capillaries. You have an infarct expansion, and people with hemorrhagically transformed infarction have a much worse prognosis than people even when they're just not reperfused. So that's why I think reperfusion, if it's too late, does more harm than not reperfusing. And most cardiologists, invasive cardiologists, are still more in favor of reopening the vessel because they say, hey, an open vessel must be better than an occluded one. This was actually brought up first by Eugene Braunwald, one of the most important figures in cardiology. He recently passed away. And this was one of his theories. He himself later on said, no, that's not the case. An open artery is not necessarily always better than a blocked artery, especially not when you reperfuse the artery during the acute event. So this is a very important piece of information. Hemorrhagic infarcts have a strong prognostic value. So it's the inflammation, infarct expansion, but then it doesn't stop there. The iron deposition, because of the hemorrhage in the tissue, leads to cardiotoxicity through the iron itself and to electrical instability. So we have other problems that are caused by the hemorrhage, by the erythrocytes that are somewhere in the tissue. So this is something that is very important. Now, I will use the next 20 minutes to talk about something very different, not so much about patients, but about prevention. And prevention, I think, is very important. Emerging countries, like across many countries in Africa, they have a problem of we expect a wave of cardiovascular disease coming in, and we also saw this in India. We had this just a bit earlier in the United States and in Europe. So the change of lifestyle, the so-called Western diet, for example, together with a lack of mobility, stress, all this increases our level of inflammation. It's the response of the body to all this. And this creates cardiovascular disease. People, because they're stressed, they overeat, they get obese, they have insulin problems, they get high blood pressure. So all these, what we call then risk factors, are just a consequence of lifestyle. And that's why we have to think about trying to help people earlier to manage their health instead of waiting until they're patients and then try to somehow stop the train. Is too late. You cannot stop the train. Slow down the train and help and maybe prevent events a little bit longer. But it's about not just living longer, but also living longer better. So the so-called health span. So when we talk about preventing disease, if we start at age 50, it's probably already pretty late, because atherosclerosis in general population is already so widely distributed. In fact, in this study, 42% of the general population had already atherosclerosis. And when you have atherosclerosis, you have events. Once you have plaques, then the risk of clinical events is already sevenfold increased. And while some people say, yeah, we can reduce plaque volume, just read the studies. We can reduce it by a few percent. We cannot make them go away. So once you have plaques, it is already fairly late. And that also refers to diagnosing this. If you diagnose plaque burden with CT, then you're basically just admitting, okay, now it's too late. So this is, from my point of view, not necessarily good medicine. We have to start earlier. We have to find risk at a stage where we can still reverse it. This is not to replace normal medicine as we know it, but to add to it. And when we think about the evolution of atherosclerosis and follow the timeline, it's actually not that this is a kind of it's harmless and then you have an event here. No, you can already have events fairly early with blockages of 10%. But what is important is endothelial dysfunction. That starts right off the bat. We're talking about 20, 25, 30-year-old people. And this is, I think, where we have to get better in the future. Now, let me talk about options to see that. Now, there's quantitative cardiac MR perfusion. And this is nice. You can see, for example, in this patient, the perfusion in the subendocardial layer is reduced. But first of all, this is with the contrast agents. So this is, again, this is expensive. You cannot use that in screening. But a second important point is that these studies almost always use adenosine or a vasodilator, a pharmacological like regodenosone. This is, again, adds additional cost. That's one thing. But adenosine is not a test for endothelial function. It bypasses actually endothelia. So the regular pathway for us, if we need more blood flow, is we send a signal to the endothelium, the inner lining of the vessel wall. The endothelium will produce nitric oxide. Actually, sunlight is very helpful in creating nitric oxide storage. So nitric oxide is produced by the endothelium and sent to the smooth muscle cells, and they relax. So this is how, in a healthy person, blood flow is regulated. It's to the endothelium. And that is important to know. And then another interesting aspect is perfusion does not necessarily mean oxygenation. So as shown in this study from Oxford, but there are several others, that even if you have a reduced blood flow, the oxygenation may still be good. And vice versa. You can, in 12% of people, they have normal perfusion scans, but they have a reduced oxygenation. So oxygenation, which is in the end reflecting the energy availability, oxygenation is not necessarily reflected by perfusion. It's just a surrogate marker. And current perfusion scans, as good as they may be, if they use adenosine, they are not using, and in fact, there is a study, a Dutch study performed a few years ago, excellent study. Patients with symptoms, most of the time, more than 80% have endothelial dysfunction. And if you do an adenosine scan, and the adenosine scan is normal, more than 2/3 of them have still endothelial dysfunction. So an adenosine scan does not give you, and let it use PET or SPECT or CMR. If you use adenosine, you're not getting the answer that you actually need. And this is where research started that many years ago, which is using oxygenation-sensitive MR. In brief, the basic principle of oxygenation-sensitive MR that deoxygenated hemoglobin acts differently in a magnetic field. In other words, a deoxygenated hemoglobin, because of the iron, acts like a contrast agent. So it turns in a signal in scans that are sensitive to the so-called blood oxygen level dependent effect, the BOLD effect. And this is known from functional MR in the brain, where it has been used since the early 1990s of the last century. There is a mechanism that allows us to track the oxygenation in the tissue if they are dynamic. Now, we have done some early studies in 2003 where we compared it in severe coronary artery disease against SPECT, and we could see that we can even if you use adenosine, that you can identify low oxygenation level in these areas, and you don't need a contrast agent for that. But we still needed adenosine at that time. But then we saw something that was very important. Breathing affects the cardiovascular system, and it does so big time. And we are using actually a protocol where we use hyperventilation and a breath hold instead of adenosine. So what happens is if you go from normal breathing to hyperventilation is that you exhale more carbon dioxide than you produce. So eventually you end up in hypocapnia. So what does that mean? A carbon dioxide is a vasodilator for the heart and the brain, only in the heart and the brain. That makes probably sense because from an evolutionary point of view, if you cannot breathe due to whatever reasons, and you have a simple mechanism that preserves the oxygenation in the most important organs, which is the brain and the heart, then you have a survival benefit. That's probably the mechanism for that. So, but anyway, so from normal breathing, if you go to hyperventilation, your carbon dioxide drops. So the vasodilatory effect of carbon dioxide drops. And the myocardial blood flow drops. And with that, the oxygenation drops. And with that, the myocardial T2 and T2 star, those are two basically measurements that you can do to assess this effect. But you can also just look at the signal intensity. And then when you hold your breath, the opposite happens. Carbon dioxide increases, myocardial blood flow increases, oxygenation increases. And we scan during that time, which gives us basically the vasodilatory capacity because these people go from more vasoconstriction to vasodilation. Now, this has also significant other aspects. People who are stressed, they hyperventilate more. And we know that panic attacks come with hyperventilation and people actually have chest pain. And then you give them a bag, and so they basically rebreathe in the carbon dioxide and thereby avoiding the effect of the hyperventilation. So this is all not new physiology, but what is new, because we can track changes in the myocardium, changes of oxygenation, we can see what this hyperventilation, what this breath holds do. And we have started that research, as I said, in 1999, have published a few papers. You can also show this both sensitivity very nicely in the periphery, in the legs, for example. We had several experimental studies in dog models, in pig models, where we assessed blood flow and looked how blood flow is affected by the breathing maneuvers. And it actually, the breathing maneuver has so this one here, 1 minute of hyperventilation, which is just 30 deep breaths. And then a breath has a stronger impact on vasodilation than adenosine. And this is just one of the clinical trials from Switzerland, showing if you put a map on it to show the increase of oxygenation caused by the breath hold, you see that compared with healthy people, people with coronary artery disease have significantly impaired so this is a patient with LAD and RCA stenosis, again, a short axis view. And then there are some people who have global microvascular dysfunction. So with the breathing maneuver, it actually, with the breath hold, it doesn't go up, the oxygenation actually goes down because they have no vascular dilatory capacity. Now, what was very interesting for me was to see that this is also dynamic across the cardiac cycle. It's not just a static thing that the myocardium is always ischemic. That would be really bad. But here are 3 examples of 3 people. On the left side, you have someone with an LAD occlusion. And what we see here, red means a normal oxygenation when normalized to the blood in the left ventricle. So here you can see that in a patient with LAD stenosis, there are certain phases where the oxygenation is lower than in other regions. So this is the LAD, and this is a patient with RCA stenosis. It's, of course, then in the RCA. And here's an interesting patient. So for those of you who are in perfusion studies, this patient has an LAD and a circumflex stenosis. And then in this area, in between these 2 territories, it looked normal. So one could ask, okay, what's happening here? That in the middle of a pathologic area, there's a normal area. And then when you look at the perfusion, you're even more confused because the perfusion is most abnormal exactly in that region. So you might say, okay, so this is actually a false negative here because the oxygenation sensitive MR says there's no deoxygenation, but shows something around it. But here's actually the opposite. Here it looks fairly normal around it, maybe here a little bit less so, but the oxygenation must be bad here. But the solution is very simple. There's a small infarct. So if you now go back and say, oh, if there's an infarct, there's actually not much deoxygenation there because there's not much oxygen demand. So this was actually correct. But then you see the deoxygenation around this small infarct, which was not seen by perfusion. So the perfusion was actually false negative for the perfusion deficit and false positive because it was an infarct. So this is just an example where oxygenation sensitive, I think, will change how we look at the verification of coronary vascular function. And now it gets even more interesting. We have seen that women with chest pain but normal coronary arteries, that they actually have an overall normal response, but the response is very heterogeneous. So some areas are really very good, some are really bad. So these women have chest pain, and while their overall perfusion can be normal, the oxygenation, the response to this breathing maneuver, and here comes the point, the breathing maneuver actually works through endothelial function. So they can have a normal adenosine scan, but their endothelial function is not normal. So the response to the breathing maneuver basically reveals that their response in the myocardium is not homogeneous. Then we have also used that in the brain and in patients with heart failure, but we could see that there is both in the heart and the brain territories, the response was reduced, and this response was actually related in the brain to cognitive function. And then we have also looked at how is that with anxiety, because anxiety people, they right off the bat, they tend to hyperventilate. So our hypothesis was a chronic hyperventilation will lead to a chronic vasoconstriction, so their vascular response should be reduced. And indeed, that was the case. And then even better, when they had a successful treatment for anxiety, their vascular function recovered. So with these tools, we can try to understand what's happening. Why do people with anxiety have a higher complication or a higher risk probability for events? And published just also, I think 3 weeks ago or 2 weeks ago, we compared it also to acetylcholine injection to coronary arteries, which is the current gold standard for endothelial function. And we could show that using markers that we can extract with scripts, so this is visually sometimes difficult, we can identify the endothelial dysfunction with an accuracy of 92%. And so we take it even one step further. We used AI, but I will talk about that next week to also extract tissue information. So from the same images, we can also extract tissue information. So we may have a protocol, no needles required, no adenosine, no contrast agent. The whole scan takes up to 1 minute, typically 30, 40 seconds are enough. And after hyperventilation, it's actually not that difficult to hold your breath that long. So it's overall, the scan could be less than 10 minutes, maybe even less than 5 minutes. And you can extract information on vascular function. And of course, in these images, you can also see the deformation. So you can extract strain and tissue pathology then with AI. So this could be a hyper efficient MR scan. So, but now I will use the last minutes to just showcase the ability of MR with a very conventional approach to help. So this was a 79-year-old patient, severe chest pain, shortness of breath, no known cardiac disease, had mild arterial hypertension. The physical exam was, she was a tiny lady, normal heart rate, normal blood pressure or low blood pressure, nothing specific, but her troponin was high. And at that time, we still had some CKMB, and she had a white blood cell count, so showing that there's something wrong. And then we saw in the ECG, we saw massive changes over the anterior wall and also the inferior wall. So then an echo was done, and the echo showed a wall motion abnormality in the apex, but also showed in the Doppler that there was an outflow tract obstruction. So there were with a and mitral valve regurgitation. So like in hypertrophic cardiomyopathy, and that was significant. And so the diagnosis there was, okay, it's hypertrophic obstructive cardiomyopathy with an obstruction delta 40 to 50 millimeters mercury. Then there was an coronary angiogram was done. So in the RCA, you saw that there's some mild stenosis here. And then there was a little bit more severe stenosis in the LAD territory, but the interventionalist said, okay, no, this wall motion abnormality that we saw in echo is not explained by that. So, but they still said, okay, there's coronary artery stenosis with 60% LAD. So we have a patient who comes in with acute events, an acute event. In the echo, we see a wall motion abnormality, but we see hypertrophic obstructive cardiomyopathy. Then goes to the cath lab and has coronary artery disease. So what is it? Is it acute coronary syndrome? Is it hypertrophic obstructive cardiomyopathy? Is it stress-induced cardiomyopathy? Is it myocarditis or what? So here's the MRI. It looks a bit similar to what was seen in the echo. There's mud regurgitation, there's blood flow velocity increase in the outflow tract, and there's a significant wall motion abnormality, which honestly doesn't look like coronary artery disease. This really looks more like stress-induced cardiomyopathy. And then when we looked at the edema sensitive images, you could see that there was widespread edema in that in that region. So this could be of course perfusion deficit and could be infarction. But then we did the perfusion. Perfusion was not significantly altered, and then most importantly, there was no necrosis. Maybe a tiny little bit here, but there was no scarring, no necrosis. So our diagnosis was Takotsubo, and follow up very interesting. So this was the initial scan, and then follow up after 3 weeks, complete normalization, 2-chamber view. Now look in the left bottom, the 3-chamber view. Normalization, the outflow tract is not a problem anymore. And here on the right bottom, 4-chamber view, also recovery of function. We also saw recovery of edema, complete resolution, and of course the late enhancement, so no necrosis. So this is an example of how important tissue characterization is. So let me summarize. The takeaways are cardiovascular MR is by far the most powerful imaging modality, given its safety, versatility, and unique capabilities. However, and while the clinical utility is established, there are limitations, mostly related to the complexity, long scan times, cost, need for contrast agent, scanner access, and the expertise needed. But there are multiple developments, faster sequences. I think the breathing enhanced OS, oxygenation sensor imaging, will be very important, and AI, I will talk about that next week, are on the way to making it the most efficient and clinically useful and also affordable scan technology we have in cardiology. And with that, I want to thank you for your attention.